All right, today we want to talk to you a little bit about the word vascular malformation. And it's really important that we use the words correctly because it gets confusing. Because this word, vascular malformation, actually encompasses the entire spectrum of things that could be malformed on the vessel side. And really it depends on the size of the vessel that's the problem. So if it's a capillary problem, that is a telangiectasia. So a dilated capillary, but it's normal in its configuration. It's just not doing anything. It looks like this little squiggly line here. Then you've got the venous version of it, which is a venous malformation. And the venous malformation in the head we call a DVA, a developmental venous anomaly. It looks like this, a big vein and maybe a little twig, something like that. You can see that these two are very low flow malformations, and therefore the risk of hemorrhage is quite low. And then we've got this cavernous malformation. You might know it as hemangioma, but I hate that word, cavernous hemangioma. And the reason I hate that word is it's not really a tumor. So a cavernous hemangioma is not really a neoplasm. It's composed of dilated cavernous endothelial line channels that have red cells inside of them. It's not really a tumor. It doesn't metastasize. It's got no neoplastic potential. However, it's got a medium risk of hemorrhage. In fact, its characteristic is that it kind of bleeds and then stops and bleeds and then stops. So recurrence is super common. And then you've got the arterial venous malformation, which is a high flow system because of the arterial flow. And this AVM is the one that's most likely to rupture. It's the one that really should be treated. So when we're doing a brain MR, if we see an AVM, that one probably needs a standard catheter angiogram and probably is going to have to be treated. If it's a cavernous malformation and it's asymptomatic or it's only bled once, we might not treat that. The cavernous malformation, if you do an angiogram on that, it won't show anything because it's not really hooked up to anything. The venous malformation and the capillary telangiectasia are super low flow, and so we definitely generally don't do anything with those. So these can bleed, but the risk of bleed is low. So this is low flow and low risk. This is high flow and high risk. This is no flow, but medium risk. And all of these lesions can occur in your orbit. They don't have to be intracranial. And so normally we can tell the difference between a venous and a cavernous malformation just on the imaging study. So cavernous malformations in the orbit, as opposed to the cavernous malformation in the brain, usually is an intraconal mass with relatively heterogeneous enhancement because it's got these cavernous channels in it. So it's actually one of the most common causes of an intraconal mass in an adult. So if we see a slowly progressive proptosis in an adult with a well-circumscribed intraconal mass, we're really going to be thinking about cavernous malformation as the cause for that. Of course, the only way to know is to take it out the path because there's other things on the differential diagnosis. And really the only way to know about arteriovenous malformation is to have a standard catheter angiogram. But as MRA and CTA have improved, we're usually able to tell the difference between a cavernous malformation and a other vascular malformation. And the cavernous malformation can press on the optic nerve and produce optic neuropathy. These other ones, the major risk is bleeding.